In today's webinar, Dr. Tom Schwieterman, Chief Medical Officer and Vice President of Clinical Affairs at Midmark, and Dr. Randy Wexler, Academic Vice Chair, Department of Family and Community Medicine at The Ohio State University, will discuss the impact of post-pandemic landscape on the medical community and its patients, and the importance of accurate blood pressure measurement for effective diagnostic and therapeutic decisions. Dr. Tom and Dr. Wexler, I know you have a lot of great information to share, so I'm going to turn it over to you now. Thanks.
Well, good afternoon, everybody. Good morning to some of our participants out there on the West Coast. It's exciting to be with you today to talk to you about this important topic. As mentioned earlier, we're going to be talking about the importance of blood pressure management and how important accuracy is at the point of care. So next slide. The key learnings from this webinar are going to center on the fact that, well, there's Randy and I. You can see our pictures and our faces as well. But to go to the key learnings, we're going to talk about how even small differences in blood pressure management can affect your management of your patients with metabolic disorders and cognitive disorders. We're going to talk about the American Heart Association best practice protocol, why it's important for your clinical care management. And we're going to specifically address the impact of patient positioning and how prepping your patients for a proper BP is a critical part of the care management spectrum to make sure you're getting accurate point-of-care blood pressures. So next slide. I think one thing all of us on this webinar, I know we're talking to a lot of senior medical group management people. The COVID pandemic has had a very significant impact on all of you and all of us. And I think we're all experiencing some of the sequelae or the long-term effects from that pandemic. One of those areas is hypertension control. As I traverse the country looking at strategic initiatives for health systems, going to the advisory board events and other events out in the marketplace, what I'm noticing is that the health systems are just now starting to come up for air, if you will, to understand what this new post-COVID landscape looks like. Dr. Wexler and I were having an interesting conversation ahead of this webinar that there was a significant number of patients that did not get the proper care management they needed during this pandemic, and some of those backlogs of mammograms, colonoscopies, cardiovascular management screenings and management techniques went to the wayside. If you go to the next slide, this has not had a subtle impact on the marketplace. This has had a very significant impact on the marketplace. In fact, if you look at the numbers from some of the studies we reviewed, nearly 500,000 individuals since the COVID pandemic and suffering from the infection have resulted in an elevated blood pressure level for themselves. And these aren't subtle numbers. Now, 2.5 millimeters of systolic and 0.5 millimeter of mercury and diastolic may sound like trivial in the particular landscape of an individual patient. But when you're looking at the population, it takes an enormous shift in blood pressure across a population of hundreds of thousands or millions of patients to create this groundswell of elevation to the level of this significant of an impact. And as Dr. Wexler and I will talk about as we go further in this webinar, even a 2.5 over a half shift in blood pressure can have a significant impact on long-term care management on an average level. What I suspect here is that Dr. Wexler and I were talking again before the webinar. What we think is happening is that the normalization of this somewhat closer to the pre-pandemic levels are starting to become more reality as our feet get under us again from the understanding what our patient population needs are and addressing those needs over time. But I would imagine we still have a long way to go until we reach the impressive numbers we're receiving pre-pandemic. And to speak of that, if you can go to the next slide, this slide has an enormous, interesting kind of spectrum from a pathophysiology as a clinician goes. If you look at the graph on the right, what you'll see is this generally downgrade in cardiovascular mortality over the last decade or two. In fact, if you go back all the way to the turn of the century, the 2000, we have had a really remarkable population health success story when it comes to cardiovascular disease. We've seen progressive and consistent declines in deaths and morbidity and mortality related to cardiovascular issues. And then all of a sudden, as you can see in 2019, and we all know the impact where this came from, a massive increase in the amount of cardiovascular deaths. In fact, if you took this graph that starts here in 2010 and brought it all the way back to 2000 to 2003, that peak that we see in the cardiovascular illness and death equals that what we saw in 2003. So in a matter of a year, we erased, decades of gains. Now, since that time, and the studies have sort of become less prevalent on the impact of COVID on disease states, but the death rates are starting to come back down. They're starting to come back to where they were pre-COVID, but by no means do I think we've reached that level of parity to where we were prior to this terrible global pandemic. So if you go to the next slide, what you'll see here is that why the rise? It's really twofold. And one area of impact is that COVID is as much an infectious disease traditional to like the flu and other cold viruses that cause an inflammatory response to a viral impact that eventually fades and disappears and the body returns to its normal state. COVID wasn't that type of illness. It was a brand new pathogen to the industry, and it creates both a immunologic and a infectious disease impact. And what we see from this is that we're starting to understand more and more what COVID did to the human body. You've heard of long COVID syndrome. You've heard of the heart effects that can happen from a COVID infection. One of the reasons for this is COVID likes to attack its cells that have what's called an ACE2 receptor. Now, that's deep clinical language, but you were probably familiar with the term ACE inhibitor for blood pressure management. The ACE receptor is central to how blood pressure is managed inside the body. So COVID directly attacks cells that had this receptor. So what you see here is a significant rise in just direct causation of blood pressure anomalies. In fact, during the year post-COVID infection, you're 55% higher likelihood to have elevated blood pressure and cardiovascular events due to this significant direct impact. Secondarily, and I think many of us, I won't say all, but many of us, including myself, fell prey to the second area of impact, which is this more situational secondary effects. Being locked into a house, having higher anxiety levels, your alcohol use went up, tobacco use went way up, the sedentary lifestyles went up. One statistic that kind of surprised me is that around 40% of Americans had weight gain during this time period. And many Americans had weight gain. 40% of them had more than 15 pounds of weight gain. So one of the success stories over the last 3 decades of why blood pressure has been successful is the awareness of the sedentary lifestyle and alcohol and tobacco on blood pressure. Well, when you turn all those off and switch them back to sort of less than desirable behaviors and choices, this blood pressure problem got a lot worse due to the fact that we were in a different state of mind and different state of engagement at those times. And what, again, I think we're starting to see some of the fallout of that become less impactful, but no doubt a lot of us walking the streets today are still carrying some of those COVID pounds that came on to be during the pandemic. So if you go to the next slide, this is not just an interesting story. It's something that we all have to significantly take into account when we manage our patient populations. So as you know, the long-term impacts of elevated blood pressure are highly, highly significant to the point where the 30-year risk is impacted by even modest levels of blood pressure elevation. 5 to 10 millimeters of elevation can take a toll on the human body and end organs over time. Your stroke risk, for every 10 millimeters of increase, you have a 20% higher incidence of stroke. And then finally, the cardiovascular and renal health issues are directly often attributed to blood pressure measurements and blood pressure goal setting. So one thing that I've been fascinated by through the COVID pandemic is with this immunological storm that happened to the entire U.S. population, a whole lot of big names, the big names of, and I'll name Ohio State in that list, Stanford's, everybody was going after understanding how the COVID virus was impacting the human body and how to better, treat active disease and prevent it. And one of what we understood through this research is this ongoing insult to inflammatory processes in the body have significant impact. Now, the reason I mention that here is that the inflammatory condition is something that every organ experiences over time. And so blood pressure sort of is like a wind that never stops. It just keeps creating this inflammatory scenario inside your vasculature, which will lead to other organ diseases. So I know many of you are in management positions in the finances of your organization are very important. So I look at blood pressure as a one-to-many benefit or harm, depending on how you spin it. Treat blood pressure well, and you're going to get multiple benefits over the top 5 or 10 chronic diseases in your patient portfolio. It's the one condition that is easy to treat. It's it's cheap to treat in many cases, and it's something that patients themselves can take a direct major role in. One area that's quite interesting on the next slide is around the impact of COVID on cognitive disorders. Back in 2017, the New England Journal, 2019, the New England Journal published a article called the SPRINT study, and they studied, over 100,000 individuals in multiple sites to see what the impact of blood pressure control is on long-term effects of human health. And what they determined in that clinical study, which was one of those pinnacle studies that changed a lot of things in medicine, is they determined first that the blood pressure control indeed is paramount to avoiding cardiovascular and metabolic disorder, cardiovascular deaths, 26% reduction, which if you're a clinician, those are eye-popping type of numbers. But what also became apparent to the researchers is that there's a new category of impact that hasn't been really well understood before, and that is cognitive disorders are absolutely often the direct result or the indirect result of elevated blood pressure over time. So for the first time in my career, there was a really clear, treatable, manageable, preemptive condition to avoid developing the Alzheimer's and dementia risks that you suffer later in life, which is really exciting stuff because for so long, this felt like somewhat of an inevitability. I just get old and this is what happens in my family. Well, for now, we have understanding that much of the risk that's attributed to these disorders can be actively managed through blood pressure control and blood pressure management. Now, what happened in that study from New England Journal, 5+ years ago, is subsequent cohort studies on the cognitive scenarios have been undertaken, and the repeatable data has sort of been accumulated that shows indeed the cognitive disorders are a blood pressure related end game. So I think it's really interesting to me that one of the top cost centers for the U.S. population is elder care, and dementias and cognitive disorders are just massive accelerants to the cost and care requirements of our elder population and those of special need. And so for once, we do have not for once, but we do have an opportunity now to primarily impact those. So to add a little more evidence here, go to the next slide. As I said, there's a one-to-many relationship with blood pressure management to the treatment of chronic conditions. You can chalk up the first 5 or 10, and I would imagine in the standard of care that you see in your best practices Q-ins that come from your EMR, blood pressure will be on most of those as a critical factor of effective management. And then also what's positive about this, and the reason it's so important, is that there is evidence to demonstrate positive therapeutic management does have the effect on mitigating some of that disease progression. And also, I think, as I said earlier, patients understand this better than they have in the past. And the self-management component of this is becoming more and more real. I think all of us have been to the Walmarts, Walgreens, CVS's, you name your retail outlet, and all of us can buy a blood pressure cuff relatively easily for your own self-screening at home. And I think that's really an advantage to us now, that patients doing their own home diagnosis, whether it's a COVID test, whether it's a blood sugar, whether it's a blood pressure, is really a powerful agent in care management. So let's switch gears to clinical practice. If you go to the next slide. As I said a couple times now, accuracy is really, really important. I think we have to be aware that when you change the protocol of the American Heart Association from 140/90, when I finished my residency as considered goal therapy, to 130/80, or ideally even less than that, you're now taking a whole lot of US population and you're shifting them from a normal category into an abnormal category. Really, I think with COVID and the impact of post-COVID elevations in blood pressure, my guess is, I don't have evidence to support this, is that we're probably at the 50-50 line now of half of your patients walking in your doors each day. 1 out of 2 will have a blood pressure anomaly that needs to be cared for and attended to, whether it's pharmacotherapy or it's some other type of intervention. The accuracy of knowing which patient in that portfolio you treat or don't treat is essential. And when you have limited office time, you have limited dollars to spend, and you're in value-based care contracts that require you to be very precise in how you deploy those resources, as I said, the blood pressure seems to be a natural place for you to consider to start. So if you go to the next slide, what you'll see here is that for the longest time, we have seen improper technique as a contributor to abnormal blood pressure. And I'm going to cue you into the vertical lines that go to 0, which is what the testers in each of these studies showed as being the actual blood pressure. On the bottom scale, you'll see a -15 to 30. That's the millimeters of mercury difference you can get when each one of these individual errors are brought into the equation of a blood pressure measurement. The one that pops out is the white coat effect. I think all of us know what this is the anxiety of seeing a doctor or having being in an uncomfortable situation. The adrenal glands get fired up and off you go with a high or low blood pressure. But the other ones are just as significant, and people often don't attribute this, whether it's having 2 cups of coffee or espresso before you have your blood pressure taken, or positioning where you're doing your feet aren't flat on the floor, the arm is at a dangling level. You're not taking multiple measurements. You're relying on the one you took the first 10 seconds the patient walked into the room. These are all highly, highly contributory to error formation, and error formation leads to incorrect blood pressure measurement, which leads to incorrect diagnostic assessment of that patient. What fascinated me upon reading this and seeing the new American Heart Association guidelines on effective blood pressure technique and management is that they assume that all of these blood pressure errors are going to have a contributory effect in aggregate. And no one had ever studied that. So I was surprised to see a national standard get developed on blood pressure technique for proper positioning, which we're going to talk about in a second, without the study being done. And I'm giving a little primer to where Dr. Wexler is going to take this conversation in a bit. We knew each one had an impact, but what happens when you don't do 4 or 5 of them? I think most of us would, be honest with ourselves. It's very unlikely that any blood pressure management only had one of these errors attributed to it. My guess is there's at least 3 or 4 in many of the blood pressures that are taken at your points of care. So what does that do? Does that synergistically add? Does one cancel the other out? So we wanted to kind of better understand that. So I am going to actually pass the baton over to Dr. Wexler, who is going to talk a little bit more about the blood pressure and accuracy, and appreciate the time. So Dr. Wexler.
Thanks, Tom. Hello, everybody. It's nice to be with you today to talk to you about blood pressure and what we think is an important aspect of that. And if I could have the next slide, please. And so what we really want to talk about is accurate blood pressure. So if everybody would think back to the last time they went to the doctor's office, maybe you were running late because the traffic was bad and you rush into the office. They check you in, they rush you to the back of the room, and the first thing they do is check your blood pressure. And that's quite frankly a problem, right? Because the recommendation is 5 minutes in a quiet room in a certain position. That's just not practical for the delivery of patient care. But there are things, and we'll talk about those later, that you can do to impact those things a little more positively. And why do we want to do that? Well, Tom had mentioned the 130/80 by the American Heart Association, the ACC recommendation. Some of the primary care groups recommend 140/90. Some of the European groups are 130/85. Whichever group you follow, we're bad at controlling blood pressure. 50, 55%, depending on how you look at. And I think part of that has to do with a lot of times people view blood pressure, especially those who take the blood pressure 20, 30 times a day rooming a patient. It's just one more checklist thing they got to go through to room the patient. And so I think blood pressure has become one of those things that's just part of the process I got to do to get the patient ready for the provider. And when that happens, it can be easy to ignore doing some of the things we were originally taught and that are very good with regards to the accuracy of that blood pressure. So when we talk about the changing of the blood pressure goals, 130/80, the reclassification affects tens of millions of Americans who would then be considered hypertensive. And so why is that important? Well, it doesn't take much to really significantly impact that. So in this particular example here, a simple 5 millimeter of mercury change can lead to a misclassification of over 84 million people worldwide, 8 million Americans. Could be higher, right? This is one snapshot, but I think the take home is it doesn't take a lot of a miss to actually have a significant impact from a population health level. Next slide, please. So let's talk a little bit more about the impact of this inaccuracy. Well, you could put people on medication, and obviously people have side effects to that. Depending on the medication you choose, there may need to be follow-up labs. So there's there's a cost, there's a time factor for the patient. But there's also some patients, if you diagnose them with the disease, they almost become a disease cripple, right? That disease process for them um, significantly impacts their sense of self. It impacts what they do, what they're willing to do. And so before we do those types of things, we really want to make sure we do this correctly. Um, there is the cough we're all used to with the ACE inhibitors, and we go, well, that's easy, we'll change that. But there are certainly worse ones than that, right? We don't want angioedema because we used an ACE inhibitor that we did not need to use that may have necessitated the patient going to the emergency room for urgent intervention. And so I think it's become so common that blood pressure being everywhere and part of the day-to-day everything, we really need to refocus on how to actually obtain a good blood pressure. And so we want to make sure people are not misclassified. Do they truly have hypertension? And if they do have hypertension, do we need to increase their dose? Because it doesn't take much of a drop in an actual patient with increased blood pressure to actually get significant benefit for them. At the same time, we don't want to be, for reasons we've already talked about, we don't want to be treating people with medications who don't need to have them treated. And so what we want to be able to do is treat the right people and treat them appropriately. Because although we all may be used to getting high elevations in readings, if we're doing blood pressures and they're wrong and we're underestimating that person's blood pressure, then that person has an increased risk for heart attack and stroke. And I can just give you anecdotal things I've experienced at the office. Every now and then, suddenly, everybody's 140/90. They're not 142/90. They're not 140/88. They're 140/90. And some of that can be due to inter-operator variability, different MA or different nurse rooming the patient. But there is literature which shows, especially if you're not using an oscillometric device, that people kind of listen to the target that they're shooting for. And if they get to the 140 and they get to the 90, it just becomes some of that background noise, and you've got these 140/90s. And so then the question is it really elevated? Is it not elevated? Again, AHA, ACC would say yes. Some of the other organizations would say no. But the bottom line is, whichever you choose, you need to do it accurately, because if you choose 130 over 80 and you start seeing a lot of 130 over 80s and no 132 over 78s or things like that, you're going to again know that you have some of this. And so the importance becomes pretty important. Next slide, please. And so let's kind of add some of this up, because anytime we do something to somebody, we tend to think of it as in a silo, but it has a significant ripple effect. So we've already talked about labs and the prescriptions, but people could end up with scheduled visits that they've got to take time off work for. Now you got the provider saying, I can't get patients in for other things. Now I've got to get everybody in for this. I think the other thing that becomes important that we don't talk about a lot is the individual who may be 30-ish and they have elevated blood pressure. And that individual, if they truly have high blood pressure, may very well need a workup for secondary causes of hypertension, which is even more significant cost. And although some of the imaging processes are not as invasive as they used to be 15 or 20 years ago, they are very expensive to get those appropriately. You have patients who, again, newly diagnosed. What does this mean to them psychologically? That can be a bit of a problem. And, phone calls to manage prescription issues. I still get prior authorization requests for lisinopril sometimes, which absolutely drives me crazy. But those things all take up time, takes time for the providers to review the labs, to order the labs. All that is taking up time that could be used elsewhere. Other things could be, again, missed appointments for other patients. So maybe you send them to an urgent care or an emergency room, and for whatever the reason is, and they really need to be taken care of in the proper place for their particular problem. You've got your incentive payments. Blood pressure's on everybody's incentive plan. I haven't met anybody who's not. And of course, the patient satisfaction, especially if they've been diagnosed with something that's going to significantly impact their lives. With that, I am going to turn it over for now back to Dr. Tom.
So Dr. Wexler and I have brought up many times the requirements for proper positioning. So if you can go to the next slide, and then the subsequent slide, what are those American Heart Association guidelines, and that have now been in place for many years? They're relatively simple and logical, and they're based on the error contributions I talked about before on that diagram. You have to have the right cuff size. You want to keep the patient quiet. You want to have them sitting and being rested for a while prior to taking your blood pressure, which can have a very significant impact. I can tell you from personal experience, 5 minutes is highly material to your blood pressure measurement. Make sure they have an empty bladder that can stimulate the adrenals and physiology of the patient as well to raise their blood pressure. Back and feet supported. Put the cuff on a bare arm, as it's just standard nursing school and medical school a technique requirement there. And then also make sure your arm is supported at heart level, and avoid crossing the legs. That can change the return of the blood flow to the heart, which can change the blood pressure as well. So what's again fascinating about this is the national standard for what is considered the best practices for taking blood pressure at the point of care. And what I'm excited to do now is actually pass it back to, if you go one more slide, add a little more color to this. On top of this, I should have added that the automated blood pressure systems are now considered to be the standard of care. I know many of you on the audience here will have still manual techniques in play, but there is a shift in recommendations and best practices towards the automated line of things, so that every patient is getting the blood pressure taken the exact same way with the same deflationary speed and triggers to identifying the systolic and diastolic pressure. It also gives the opportunity to do bullet 2, which is not possible in a manual system, is to have the patient sitting alone, which could have a ability to reduce the white coat hypertension. So anyway, so what I'm going to do is pass it back to Dr. Wexler to talk about something that we did very exciting, or Dr. Wexler did very exciting, on what is the effective and proper positioning at the point of care. So I'm going to pass it right back to you, Dr. Wexler.
All right, can I have the next slide? So I'm a family physician. I'm not interested in chopping up a rat thymus and running it through a chromatographer or machine and trying to figure out what's going on at the molecular level, though that is important as well. I just want to know what's the best way I can take care of my patients when things come to the clinical aspects of things. And that's what we're really talking about when we're looking at the summative effects of everything that's being recommended for how to take blood pressure. In fact, recently, just within the last week, just a single change. JAMA in Internal Medicine had an article. Johns Hopkins did a study just on arm placement, which showed a significant impact in lower blood pressure. And so what we wanted to see is if you package everything together, what might that summative total be? And so we did that. It's called the Correct BP study, the comparisons of outcomes for routine versus American Heart Association recommended techniques for blood pressure measurement. We published this in eClinical Medicine, which is part of the Lancet family of medicine journals. And I want to talk to you a little bit about that and what our experience was and what we found. Next slide, please. So what we did was we wanted to see, well, if you look on the far right of this picture, this is what the exam room looks like, right? You've got your standard table. The patient climbs up on the table. Their legs are dangling off. So most of the time, at least in my office, the back portion is really not up. And even if it is, it doesn't really support the back. The patient kind of leans back on the back. The blood pressure cuff is stuck to the wall. So basically, we've done nothing correct. Can't support the arm here. This is kind of the traditional way the room was set up. And we wanted at a number of times before Tom and I even talked about this study, we tried to get our wall sphygmos moved from where they were to the other side of the room so we could take people's blood pressure sitting in a chair. And I'm in an academic medical center, so you can't just unscrew it and move it yourself. You got to have the people who do that come out there, and the cost for that was cost prohibitive. We just couldn't do that. It just made no sense. And so we started thinking along the lines, well, what if we actually did all of this type of stuff? And so what we did here was we compared what does the blood pressure look like between doing a blood pressure to a patient on the right, and if somebody is using a modality on the left where you're sitting appropriately, your arm is supported, there's back support, all the components that are supposed to do this. This was conducted at my office. It was a randomized prospective study. When the patients were recruited, we had researchers. We were supported by the central research team at Ohio State. They came and did all of that. They are separated from us. They collected all the data, did the whole intervention. We did this on 150 individuals over the age of 18. And what we really wanted to do was see what's going on with the automated device and how it was done. And then we wanted to also see how it was done otherwise. Now, a lot of us are not used to automated devices, but over the last number of years, oscillometric devices actually, the newer ones, and if you use an approved one, are actually quite accurate. But that also requires proper technique because especially if you put an oscillometric device over clothing, you dampen the pulse wave. And so you're going to get a less obvious reading than you would. In fact, the European Society of Hypertension specifically recommends the use of an oscillometric device when doing blood pressure. As is true with anything, you want to make sure you have one that has been validated, and everybody can go to the Validate BP website. Gives you a whole list of options for blood pressures at home or even at the office to do that. Next slide, please. And so on the left-hand side, you'll see kind of how our flow was. We ended up recruiting 158 individuals. 8 we could not enroll simply because their arm circumference was too big. I'm sure you've all experienced this. It's how do you get an accurate blood pressure on somebody who's got a really, really big arm? And that's something everybody struggles with. But especially when we want to make sure that our results are accurate, we want to make sure that it's not even a question as to whether that individual's arm circumference was accurate. Once we did that, they were randomized to groups A, B, or C. And group A was table first, then chair. Group B was chair, then table. And then we also did group C. And the reason we did group C is we wanted to go chair, chair, because we wanted to make sure that it was kind of a self-check. We were making sure that what we were doing was still accurate and appropriate. And you can see what our outcomes were here. It's going to be a little more dramatic on the other side when we talk about it. You can also see that our p-values are all very strong with regards to all this. And so remember, the patient came into the room, they were put in the appropriate position. First, we let them go to the bathroom, feet on the floor, back supported, arms like. Here's the other thing. We all have talkative medical assistants, completely understand. They're people, they want to be around people. But when you're checking blood pressure, don't. It's like the dentist trying to have a conversation with you when they're cleaning your teeth or they're doing something else with a big metal hook. That's not the time to have the conversation. Doing blood pressure is not the time to have the conversation. So we needed a control for all of these things to see how we could come up with the following of all the recommendations and what that would look like. Next slide, please. And what we saw was this. When done correctly, comparing the utilization of putting the patient in the proper position versus putting the patient in the usual position, the difference was 7 millimeters of mercury systolic, 4.5 millimeters of mercury diastolic. That's a boatload of difference when it comes to patient outcomes. It's a boatload of difference when it comes to patient classification. When you start looking at your heart failure patients, so we're talking about blood pressure now kind of in a silo, but when you're talking about your heart failure patients, when you're talking about your kidney disease patients, when you're talking about your diabetics, we're talking about being off by a couple millimeters of mercury can have significant decision-making trees, some costly, some under treatment-wise, that become really, really important. And so reiterating what the AHA recommends, feet flat on the floor, support the back, lumbar support in particular. Don't just have the patient lay back. Arms supported, not dangling. What we tuck the patient's arm underneath our arm and we kind of hold it there. And it's kind of dangling. And depending on the patient's height and the height of the table that we all use, that's most likely not going to be at heart level, which is where we need it to be as well. And these were the things that we looked at. And this is what we found statistically as being the outcome. And a lot of these are completely avoidable. And they can also be done in, the change can be done gradually, right? So what we started doing is we just put a chair in all the exam rooms next to the blood pressure cuffs. So now at least we have a patient who can come in and sit down and put their feet on the floor. It's not dangling. But we still got the blood pressure cuffs on the wall. Luckily for us, about 3 months ago, so a couple years after we had completed this, facilities management decided it was time to repaint the office. Well, if it's time to repaint the office and you got to take those things off the wall, we want you to put them on this wall because we want it over here next to this chair. We want it away from the table. And so we were able to do that a couple years later. And we've talked to our medical assistants about, we know you want to talk to folks, but when you're doing the blood pressure, we really have to watch doing that, especially to get the accuracy. And so you can do a lot of these things as the opportunity arises, for lack of a better term, because certainly trying to change 3 or 4 things at a time, that's also a prescription for having issues, and we don't want anybody to do that. So our particular change occurred over a couple of years, and we've seen significant improvements in blood pressure goal achievement. But again, if it's not accurate achievement, we're not doing anybody any favors. On the right-hand side, again, the article, it is free. Anybody can go online and access this. You can see what we've done and the comparators that we used. And I think just the most important thing to remember is it's like we talk about with computers, right? Garbage in, garbage out. Same thing with blood pressure. If you're not doing it right, whatever you're acting on has ripple effects down the road and significant ripple effects. One of the things we also did was we talked to some of our specialty providers. We said, look, if you're not going to use blood pressure, maybe you don't need to check it. We had offices that were doing wrist cuff blood pressure readings, and the patient was sitting on the table and doing these other things. Then when we get the letter, we're like, well, this blood pressure is elevated. I need to bring this patient in to see if it's really elevated. So it's important, especially as we're all integrated, to remember the ripple effects, not just within a particular office, but across the system and all the specialties that patients go to. And with that, I will turn it back over to Dr. Tom.
Yeah, and stay on the slide because I have another point. There are a lot of members on this call that are financially minded. Productivity and achieving population health metrics and goals are part of your your goal setting. And what I'd like to argue to you is perhaps your clinical team is better at managing blood pressure than they think, that maybe they are not doing the right technique. And you could get a nice 7/4.5 improvement in your blood pressure measurement population health measures by simply doing the proper technique. And the positive thing from a Hippocratic Oath standpoint is this is a first do no harm gem that you're more likely to de-risk somebody, avoid medical management intervention. You're going to have more satisfied patient population who's going to be more trustworthy in you as an accurate diagnostician because of the fact that you're taking careful attention to this primary keystone, as I called it, in your management of many of the top chronic disease states. So if you go to the next slide, I want to kind of go further to where Dr. Wexler was going with respects to what can you do. So if you go to the next slide, it's pretty simple to actually redesign and consider your exam space as part of the fundamentals of how to do this properly. As you know, workflow is a very, very complicated, significant part of any clinical practice dynamic. So setting up the room in a workflow scenario that'll make sure that when your MAs or your nurses or wherever's working in your office space that day can do the technique exactly the right way the first time and every time. So there is equipment out there. Obviously, the company I represent, Midmark, has this where all of the AHA protocol attributes are effectively managed, including the blood pressure and averaging that can be done through the blood pressure measurement machine and the vitals device. So I just encourage you to think about the ROI on the concept of reducing your blood pressure values at a 7/4.5 millimeter, again, confirmed by the Hopkins study, which happened after the publication of this deck. It's becoming very apparent to I think the industry that the how is just as important as the what you do for blood pressure. So just encourage you that if you're redesigning your office or if you're thinking about what you can do in the long term or even short term for that matter, this is a really compelling scenario for you to consider to simply put the right equipment in the room to support the positive benefits that come from a proper blood pressure. So I think we're right at time, and I'll end with this statement that I believe wholeheartedly. If next slide, the blood pressure is the single most important vital sign. It is the keystone of your management for all your top health measures and chronic disease management conditions. So let's treat it that way. So I'm going to pass it over to Craig, who I hope has some questions or some feedback from the audience.
All right. Thank you, guys. A lot of great comments from the audience, and we do have a couple that we'd like to jump in on. I think the first one is a patient at higher risk when they have any of the factors such as caffeine use, a full bladder, etc., or does the best practice reading only, is that the one that only truly matters? Do you understand that question? That's how they worded it. I'm trying to piece
I think
here.
so. The patient's not at higher risk per se, but the risk is the blood pressure being elevated when it's really not. And we have the risks that we discussed that flow from that. I think it's also important. So caffeine, which is an important thing, I'm glad you brought it up. You don't want anybody to have a caffeine 30 minutes before they get their blood pressure taken. If they're a cigarette smoker, it's the same thing. And, we all have patients who get brought back in the morning for their first appointment. They got their cup of coffee in their hand. And if it's elevated, it's elevated. If it's not, okay, but then we have the conversation about the next time. The reason you want to have the individual empty their bladder is a full bladder triggers autonomic mechanisms that can increase the blood pressure, even though that's not your true core blood pressure reading. And so that's why you want to have the empty bladder, because you want that accuracy. So if I'm understanding the question, hopefully I was able to provide what you were looking for.
Yeah, I think that's
Craig, if I could jump in here also,
yeah.
I saw a couple comments come about around home blood pressure readings, and we neglected to really go into that in any depth. What I'd like to comment on that is that there's research out there, legitimate research out of Stanford, conducted by the United States Preventive Task Force, that analyzed all the locations for blood pressure attainment and mentioned that home is a critical part of the management portfolio of a doctor's treatment. However, with all variables considered and all studies and all biases removed, the point of care at the clinical office site remains the best location for affirming and diagnosing a patient with elevated or abnormal blood pressures. Now, having said that, the home blood pressure readings are absolutely central to titration and making sure that the white coat effect isn't part of the pathophysiology, that you're actually identifying the patients with the right blood pressure. So we are, I'm very much bullish on the need to do at-home blood pressure readings, but I think that only adds to the need for credibility and substantiation of the in-clinic site visit measurement.
Yeah.
So I just want to make sure we touched on that.
And if I could add one thing about the home blood pressure readings, please don't send the patient to a store to purchase whatever one's on sale that day. The Validate BP site will tell you which blood pressure cuffs have been validated for home use, also office use. But that way, you know, and in fact, there are a couple recently of wrist ones that are there. Typically speaking, the wrist ones, except in certain situations, are not what you want to use. But there are a couple there that have actually been validated. And if something's on the Validate BP website, absolutely, go for it. I have the patient get it if that's what they want to use. But we want them doing that. We also don't want them getting their grandparents' blood pressure machine that's been sitting around the house for the last 10 years that they never used. So it really is about accuracy.
Interesting.
All right, that's some great info. Just had a comment come through into chat, and I'd like your comments on this. We are using standard chairs with back and arm. Can those be a good alternative? What's your opinion on that?
Again, we tested on the equipment that we knew would put us in the exact right position for the proper BP, which includes the mid-mark device. But absolutely, as Dr. Wexner, now stealing his thunder here, just making sure that you're attentive to these attributes of best practices. Even if you're telling your patients at home to instruct them on this technique as well, like make sure you're sitting upright and have your back supported, your arms on a table, have the blood pressure cuff at about the heart level. It's not that cognitively challenging to understand. So yeah, I absolutely, there's intermediate steps that can be taken to get you 90% of the way there.
Okay, excellent. And I guess just to be even more specific, are the study's authors suggesting healthcare providers replace tables and chairs used in blood pressure measurement in the exam rooms because of these findings?
That becomes well, I'll phrase it this way. You will get a more accurate reading if you do that. I think we've shown that in this study. I think what it comes down to is what can be done at the time, and do you make incremental changes? What we typically do with our quality dollars is we buy things to make our quality better. So the quality dollars flow down to our offices, and different offices have interests. And so we use those dollars to actually continue to improve on our process for how we're doing things by purchasing things that will continue to improve that quality. And so it's a journey. It's not a light switch. You're not going to flip the light and boom. But it's something that can be done over time. There are things we've done where we have done one room and then we do another room. And we do things that way to get to where we want to get to, recognizing the office I'm at, we've got 18 exam rooms. If you go and outfit 18 exam rooms, the administrators are going to come lock you in the closet. So it's what can you do and how can you do it and what can be done incrementally. And so that's what we've been doing at my office. We took the opportunity for the repainting to move our blood pressure cuffs from the wall next to the table over to another wall by the chair. But we've also, over time, purchased devices and things with our quality dollars that then continuously support what we're looking to do. They're not in every room at all the same times. It becomes a long-term process for us. And that's how we've approached it.
Great. Just had a comment roll in. It says, literally was in a value-based care meeting yesterday discussing management of blood pressure metrics. The focus was not on the front end use, but the referral follow-up process.
There
They're
you
just
go.
saying that the education is super valuable regarding where the focus efforts to obtain accurate data and, getting the correct level of care, potentially unnecessary visits, eliminating those. So just kind of reiterating that they're finding a lot of value in this and
Well, I'll add to that. Medicare value-based or Medicare Advantage and value-based care programs in the central, you simply can't afford to utilize that specialist in the fee-for-service mindset. It's way too expensive. It's way too underutilization of a specialty provider. And I think Dr. Wexler and I know we're both family physicians, and this is 100% in the purview of a family doctor's care management requirements of performance. So to your point, I think in the value-based care world, it's financial malpractice to send a patient to a specialty provider when you are misclassifying someone. And we're starting to have that discussion in dental care, by the way, as well, making sure the dental providers who are taking blood pressure are doing it properly as well, because that comes into the family doctor's office as a hypertensive urgency scenario when the patient really isn't that sick. So anyway, great points there. Value-based care is driving this equation in many respects.
And if I could also mention around the value-based continuum, in addition to the referrals, which when family docs are busy, sometimes it's easier to just do the referral. I can't get this patient's blood pressure controlled. I'm going to refer them to in different places, different specialists too. Maybe it's the nephrologist, maybe it's the cardiologist, maybe you have a hypertensive, whatever it happens to be. In addition to the cost of that referral, part of the problem also then becomes that you're missing out on opportunities from that cost-effective standpoint to manage the patient. But taking a little further, if you get the blood pressure right the first time, you don't bring them back in 6 weeks to recheck it after you've made another change, which then opens your access for those other patients. And the less we kick down the road, the fewer patients end up being sicker because they can't get in, or again, in the high cost practice places, urgent cares, emergency. Where I am, there are freestanding ERs everywhere. And I can also tell you, half the time a patient of mine goes there and they think it's an urgent care, and they get upset, they get an ER bill. Half the time they get sent to the real ER at the big house. We have a number of systems here in town, and the patient ends up with a second bill because now they go to that ER. And so these are all things that are built in a response to a system that's really not designed maybe the way those of us who take care of patients want it to be, but it is what we live with. And so getting things right and keeping people from that becomes significantly important. And remember, it's not just blood pressure, it's what's the blood pressure on your diabetics, what's the blood pressure on your heart failure patients. So when you're talking about value-based care, we may look at things in specific silos based on disease name, but blood pressure goes across everything.
Yeah, great point. I think I'm going to finish up with just the last question on, do you guys have any recommendations of additional resources that they can share with their providers or their other staff to help show them more about, your study and kind of this topic?
Yeah, so the study you can go download for free. That's not a problem. You can even just Google the correct BP and it'll probably bring it up.
And that was Lancet's decision to make that publicly available because of the clinical significance, which I think is interesting. So,
yep.
On the other side, I think Target BP from the American Medical Association is a wonderful site.
Mention.
Okay, great.
Yeah.
And honestly, this is a topic that you do a Google search. It's becoming very hot in the clinical sphere. You'll find very good review articles recently published.
Yeah.
So those are the sites I think we'd go to.
And the American Medical Association has some really good tools, both for patients and for providers.
Yep.
And so I'm on Epic. Probably most of you out there are on Epic. So I have a preset smart phrase for my hypertensive patients. And as part of that is the picture from from the American Medical Association toolbox on how you should be taking your blood pressure at home and when. And so I tell them this is the proper position, and now I can give it to them and say, this is how we want you and why. And so I would say that's as Thomas mentioned, another good place to go, because there's tools for both patients and providers.
And Midmark/Better BP. So I'll throw that little commercial in at the end.
All right. Well, thank you guys so much for your time. Thank you, Dr. Tom. Thank you, Dr. Wexler. And thank you everyone for joining us and participating in today's program. The education for this session is now ended.
Thank you, everybody. It was fun.
We'd like to thank Midmark for their sponsorship. Visit their website at midmark.com/betterbp for more information on how healthcare providers can help ensure accurate, consistent blood pressure capture. If you have any content questions, please direct them to Dr. Tom at Tom Schwieterman at midmark.com. Or you can also, they're on the slides as well. If you have any webinar related questions, contact ed at mgma.com. Be sure to complete the evaluation, which will be available in the learning management system in about 10 minutes after we sign off. And after earning your certificate of completion, which is required to claim credit, please allow 24 hours for the system communications. For information on all our conferences and webinars, please see the MGMA events page. Thanks again, everyone, for attending, and we'll see you at our next online event.